All right, so today we are going to be getting started in your CPT book. So you'll want your code book handy, and I'm also using chapter 13 in your Fordney book as a guide, but I'm not like lecturing the chapter. I'm just going to use it to make sure I don't miss some certain concepts, and there's a couple things I want to talk about in the chapter. So I'm on page 255 in your Fordney book if you want to follow along, but mostly we're going to be using the paper code book. So CPT stands for current procedural terminology. So procedures, these are the things that we do to a patient to either evaluate, test, or treat something they may have wrong with them or some symptoms they're complaining of that we're trying to figure out what is causing those. So that is the use of this book. It's going to be used in conjunction with your ICD book because your ICD is the diagnosis or the symptoms as to why we had to do these procedures. So the diagnosis justifies the procedure. Okay, so they're used together. Every patient needs to have a code from both book assigned on every visit. Okay. Just like your ICD book, your CPT book has an index and a code section. So just like in your ICD book, you're going to start in your just like in your CPT book, you start in the alphabetical index to figure out where to go. So I'm here in your alphabetical index, which in your CPT book is towards the back of the book. In ICD, it was in the front of the book. CPT, it's in the back of the book. So I have up the entry for brain. And these are all the things that we can do to the brain or that might be wrong with the brain. The patient may have an abscess. We might be doing a biopsy. We might be doing radiology. We might be doing an excision of some kind. An excision of what? Oh, here's all these things we can take out of the brain, okay? So it's quite a long section. So we would look up our word, go to the subsection, and get an idea of where we go. So let's talk about what words we look up. In ICD, it was very specific. You had to look up the main word of what was wrong with the patient. Here in CPT, we can look up the main word of the procedure. So we did a removal, a drainage, a biopsy, an injection. We can look up all those words. But we can also look up the body part. That was forbidden in ICD. If you look up the body part, you will not find what you're looking for. But here in CPT, you can. You can also look up an abbreviation. So if we did an MRI or a complete blood count, we can look those up. We can also look up what's called an eponym, which is a procedure named usually after a person. So Grey's Anatomy, they always do a Whipple. It's a pancreas procedure. It's probably named after a Dr. Whipple who created that procedure. But guess what? You look up the Whipple here in CPT, you'll find the code. Okay. The last word you can also look up is the medical term for the procedure. So let's say we did a removal of the gallbladder. So the main word of the procedure, we did a removal. Same thing as an excision. Not sure which word it would be under. Could be under both, could be under just one of them. You could look up the body part. Or you could look up the medical term. So if I look up one of those, you look up a different one, somebody else looks up the third one, and we all find the right code. We all did it right. There is no wrong way. The only wrong way is if you don't find the answer. So if you find the answer, you did it right. Okay? So there's not one of these ways that's better than the other. This is a skill and technique that you will develop over time and build your coding skills. Me, I tend to be a body part kind of person. I tend to default to the body part. Most of my students tend to default to the procedure, unless you're given it already in a med term, and then they kind of use the med term one. But they don't typically create the med term word themselves. So if they were told removal of the gallbladder, they don't go to cholecystectomy, typically. It doesn't mean some people don't, but kind of, there's no rule. Like I said, as long as we all find the code, we're good. Okay, the next thing I want to talk about is what does a CPT code look like? 5 digits, no decimals, no letters. Look at all these codes that they're referencing over here. They meet exactly what I just said. 5 digits, no decimals, no letters. Always 5 digits, never ever less. So sometimes the code starts with some zeros to make it be 5 digits. That's okay. Those are your anesthesia codes. Okay. Notice that when you look up an entry here in the index, sometimes it references you to one code. Sorry, I have a cat jumping up. Sometimes it gives you a couple of codes, and sometimes it gives you a bunch of codes. When it gives you a bunch of codes, guess what? You got to look at all of them. Any of them could be the right answer that you were looking for. If that's the entry you were looking for, all of those are possible suggestions. You got to look at them all. Now, that does not mean when it only tells you one code that that's just the answer. Just like in ICD, you got to go to the code section, look it up, and confirm it. So let's look at this drainage of the abscess, this one right here. 61150, 61151. So let's go to the code section of our book and find that code. So you do it, I'm doing it. I'll have it on the screen once I know a page number. So these are the codes that we find. And so we need to look at both of them that they suggested and decide which one fits this patient this time. And we're going to look at our doctor's documentation, and we're going to make our decision. These codes actually create another example, a good example that I was planning on showing. So these codes actually are going to be my example. So I drew a line at the margin, and you can see that codes 61150 and 61151 are indented just a little. I drew the little dash. Okay, they're indented just a little from the margin. And that indent means something. And that indent is actually tied to the usage of this semicolon right there. Okay. And this part of this definition before the semicolon is going to come into play. So let me put all these concepts together and explain to you what it's telling you. Okay. When a code is indented, like 61150 and 51, it means that the first part of the definition is carried down from above. So the code not indented above it is the beginning of that code definition. And the part that's carried down is the part before the semicolon. So the code 61150 actually is defined as burr hole or trephine with drainage of brain abscess or cyst. So we put together these two phrases to make our code definition. 61151, burr hole or trephine with subsequent tapping or aspiration of intracranial abscess or cyst. This, it starts up here and then jumps to here and puts those two, the part before the semicolon and then the part at the actual code put together. So this part after the semicolon only belongs to 61140. That part does not get shared. The part after the semicolon stays at that code, does not get shared below. What it does is it saves printing in your book, and it saves your eyes having to weed through more words, which makes it quicker to code. Okay. The next concept I want to talk about is not one you see a lot in the brain. You see it tremendous amount in the skin. So I'm going to jump to a skin code. Whoops. So go ahead and pause your book or pause your video and turn in your book to codes 11102 to 11107, and we can talk about these concepts. So just restart the video when you're ready to continue. But I want to talk specifically about this plus sign that's being used on this page. Anytime there's a symbol, it means something. You can't just ignore a symbol because you don't know what it means. Symbols are defined at the bottom of your book, both pages. Every page has the symbol definition. So when you just don't know what it means, you just look to the bottom of the page and you go, oh, okay. And then hopefully it means something. So this is an add-on code. An add-on code cannot be used by itself. It must be added on to another code. So the other code goes first, the add-on code gets put second. So you would use these two codes together. So you can see 11104 is a punch biopsy of the skin, semicolon, single lesion. 11105 is indented, so that means it's still the punch biopsy of the skin, each separate and additional lesion. It's telling you to add this on to the primary procedure, which the first lesion is the primary procedure. And it tells you here what codes it can be added on to. Okay. So don't add it onto a code that it doesn't allow. So if my patient had one lesion, I would just code it as 11104. If my patient had two lesions, the first lesion, the additional lesion. What? I heard someone ask, what happens if they have 3 or 4 lesions? Oh, that's a great question, whoever asked that. You still need this one for the first lesion. This code is for each additional lesion. So if the patient had 3, and the one pays you for the first lesion, you have 2 additionals times 2. Just like that. What happens if you forgot that times 2? The patient had 3, you forgot to put times 2, so you got them paid for the first and 1 additional. And you forgot about number 3. You know what just happened? You lost your doctor some money. Your doctor is never going to get paid for that third lesion of work that they did because we forgot to add a quantity. So that's a big deal. Do that a couple hundred times in a year, and you just lost your doctor a couple of $1,000s over the course of a year. Do that on big procedures, and you might have lost your doctor tens of thousands of dollars over the course of a year. So yeah, that's a big deal. Okay. All right. I want to notice that there's a bullet here in front of these codes as well. Remember, I told you never see a symbol that you don't know what it means. Look at the bottom of your page in your code book, and you'll see that that's a new code. Now, if you are, whoops. If you are using a 2019 book, like I am, and my digital one on the screen is also a 2019, you'll see those bullets because those codes were new in 2019. If you're a newer student and you're holding a book from 2020, you don't have those bullets because it's no longer a new code for you. For you, it's now the second year that code has existed and that bullet disappears. So that is definitely one difference between having the newer code book. You're not going to see that. Now, you having a 2020 book, you may have bullets on other codes that are new in 2020. So guess what? Me holding a 2019 book, that code doesn't even exist to me. So you have a better book overall, which is why we need new books every year. Now, do we need them as students? No, I do just fine teaching from a 2019. Honestly, I could teach from a 2018. It wouldn't matter. We're teaching concept, and that concept does not change from year to year. But if I was coding for a doctor in the real world, and I was trying to bill out using a 2019 book, I will never know what changes happened in 2020 because my doctor was too cheap to buy me a new book. So as a biller and a coder, I have to be insistent and stand up for myself in my department and insist on new books every year. Doc, it's a couple $100, and it will make all the difference in the world in accuracy of me doing my job. It is worth a couple $100 every year. You've got to give me the tools to do my job correctly. Okay. I want to talk about modifiers. So what I want you to do is to open your CPT book to the inside front cover. And we're going to be looking at this inside front cover. Give me just a second to get my book to the same page. Okay, so the inside front cover, and it's on my screen, starts out with the symbol definitions, the same ones we've already talked about. And then it has this cheat list of modifiers. Modifiers, you can see, are all 2 digits, but if you look at the inside front cover, you'll see that some of them start with letters, some of them are 2 letters, some of them are letter number, and some of them are just numbers. Yep, it'll never be number letter. That combination doesn't happen, but the other 3 combinations do happen. The most common time you use them, well, what a modifier is it better explains how a procedure was performed. So the procedure, sometimes that modifier is just informational. For example, these are very common ones to use in the classroom, left and right. So we're just telling the insurance that we did that procedure on both sides of the patient. So we did, let's say we did procedure 1, 2, 3, 4, 5, and we did it on the left side. This is how you add a modifier. Hyphen, LT, both capital letters. Okay? Sorry, I have a pretty insistent cat this morning who wants to go outside. I'm going to go lock him up in a minute. Sometimes that modifier is going to change how much we are paid. Sometimes the procedure we did was like bigger than it normally is. Sometimes it's lower than it normally is. And so we would use that increased or reduced services. And using those modifiers is either going to get you paid less or paid more, depending on the circumstances, because you're entitled to be paid more, or you're not entitled to be paid the whole amount because you did something only partially. Okay. Sometimes there's 2 surgeons, and they're going to split the reimbursement between 2 doctors. Sometimes it's just informational. But the more you use with modifiers, the more this makes sense, the more you're familiar with what's here. We're just going to do like a little overview today. You're going to have a mod where you actually learn a whole modifier chapter, and you're going to spend a lot of time with this list and get familiar with what's here. But that's all we're going to talk about for today. Okay. Couple of things I want to talk about that are going to help you with your ICAs. Let me just get my book to the right page. Okay, in your Fordney book, I'm on page 279 if you want to follow along. This is going to help you for an ICA in class next week. Okay, so downcoding and upcoding are the 2 concepts I want to talk about here. Downcoding means that we are coding lower than the procedure we actually did. This is going to result to you in lower reimbursement. Okay. Sometimes doctors do this on purpose because they think they can fly under the radar of getting audited, which is a bad idea. Sometimes this is done simply because our doctor didn't document good enough, and so maybe we think he did this higher code, but he didn't document it. So we have to code it lower because that's the documentation we were given. And so sometimes we have to downcode not by choice, but because documentation is just poor. Okay. Upcoding is the term that means deliberate manipulation of a CPT code to increase payment. Okay. This is a bad idea. This means this is the code we performed, but I'm going to code it higher because I'm going to get paid more. Notice that word is, the definition there says deliberate manipulation to increase payment. Medicare has a word for that. It's the F word. It's the 5-letter F word called fraud. That's a big deal. This is not something to fool around with. So you code what was performed. End of story. We don't code higher than the documentation. If my doctor says, but I did this, I'll hand them back the chart and say, then document it. I code what you document. You give me better documentation, I can give you a better reimbursement code. You didn't document it, I don't code it. Okay. The next concept I want to talk about is the global package. I'm going to pause. Okay, so I'm on page 268. This is going to help you with today's ICA because today's ICA has to do with post-op visits. So this is going to help you answer that. The global package is when all of the care for that procedure is billed together. So if you're getting some stitches, maybe we had to clean it out, we had to use some tweezers to maybe get some glass out of the wound, we used a needle and thread to stitch you up. Oh, before we did that, we gave you some lidocaine to numb your area, doctor put some gloves on, we gauzed it when you got done. We don't get to bill all of those supplies separately. We're just going to bill for the stitches. And when the reimbursement was determined, all of those things were thought about because all of those things are necessary to put some stitches in your hand. Okay, so they considered all of those supplies when they decided how much money to pay you. Okay, that's called a global surgical package. The other concept is called a global period. The global period is a time frame. There's only 3 time frames: 0 days, 10 days, 90 days. We have minor and major procedures. What this means is that when you have a major procedure, you get your gallbladder out, you had a baby, you had brain surgery, orthopedic surgery, any kind of big thing, 90 days of follow-up care are included in the doctor's payment for that procedure. So when the doctor did the surgery, delivered the baby, 90 days of follow-up care was paid. Even if you never come back for follow-up care, he's going to get that money. A minor procedures like stitches, things like that, 10 days follow-up. And then there's like super minor procedures that have no follow-up. Like if they want to look at my voice box, they're going to put a scope in, look at my larynx, my pharynx, all that stuff, and then pull the scope out. No follow-up care is included because I should not need to come back. But guess what? Those stitches, I need to have them taken out. I come back within 10 days, they don't charge me to take out the stitches. If I have a baby or I have my gallbladder out, I come back in those 90 days just to check up, make sure I'm not doing bad, no charge. When I say no charge, I mean no charge for normal follow-up care. I had orthopedic surgery. A couple weeks into the surgery, he takes the cast off, he takes an x-ray. That x-ray was not included in the global package. They charged me for that, my insurance for that. The other thing that is not included in a global package is complications. Let me give you an example. I have my appendix out. I come to the doctor a week later for a follow-up. He says, "How's your pain?" I say, "Yeah, I'm doing fine. It hurts a little bit, but that's normal." And he wants to see my wound. So I lift up my shirt, show him my incision, and it's infected. It's oozy and pussing, gross. He has to cut open the wound, clean it out, put some antibiotics in there, sew me back up. They're going to charge me for that. But same appendix, he looks at my wound, everything looks great. That visit, no charge. 0. Okay. So all of that has to be thought about when I'm coding that visit. So do I charge for today's follow-up or is it included? Did I pass the 90 days? What if I come in on day number 92? I passed my 90 days. You're going to charge me for that visit. Even if it's no complications, you're still going to charge me because I passed the date range. I had orthopedic surgery on my foot, and my doctor knew exactly what day number 90 was. We were getting close to it. He opened the chart. It said right in the chart what day 90 was. And he goes, "I need to see you before this date for one more checkup. Don't come past that date or you're going to owe for it. So make sure you make that appointment prior to this date." He was really clear. Like he was on top of it. He knew what he was doing. I knew what I was doing because I do this for a living. But for somebody who didn't know what that meant, That's a very helpful thing that a doctor just did, was to make sure I didn't incur an extra bill because I didn't know that I shouldn't. Okay, so this is going to help you with your intro. I'm teaching 2 intro coding classes that I suggest everybody, no matter how experienced you are, attend. We're going to do a Zoom on this Thursday, which is the 16th, from 1 to 3 on ICD. We're going to do another one next Monday, which is the 20th, also from 1 to 3. Your directors should be posting your Zoom links. So one's on ICD, the other's on CPT, to get you guys just better and better and better at building these coding skills.